Angiotensin Receptor Blockers or ARBs, also known as Sartans. ARBs are a class of medications that target the Renin-Angiotensin-Aldosterone system to manage cardiovascular and renal conditions. Before understanding how ARBs work, let us first review the Renin-Angiotensin-Aldosterone system. What ARBs target? Angiotensin II is the major effector hormone of the renin-angiotensin-aldosterone system. Normally, it produces vasoconstriction, stimulates aldosterone secretion, and it causes increased sympathetic activity. ARBs act by selectively blocking angiotensin II type 1 (AT1) receptors, preventing all these actions of angiotensin II. Now let us understand the mechanism of action of ARBs. The first effect is vasodilation. By blocking AT1-mediated vasoconstriction, ARBs decrease peripheral vascular resistance, leading to a fall in blood pressure. Second, they reduce aldosterone release. This increases sodium and water excretion, lowers blood volume, and further contributes to blood pressure reduction. ARBs also decrease sympathetic activity because inhibition of angiotensin II reduces sympathetic nervous system stimulation, thereby decreasing cardiac workload. Finally, ARBs exhibit bradykinin sparing. Unlike ACE inhibitors, they do not inhibit bradykinin breakdown, so dry cough and angioedema are much less common. One of the most important advantages of ARBs is bradykinin sparing, which is their key differentiator from ACE inhibitors. Unlike ACE inhibitors, ARBs do not inhibit bradykinin breakdown because they block the AT1 receptor rather than the angiotensin converting enzyme. As a result, bradykinin does not accumulate. This explains why dry cough is rare with ARBs, making them an excellent alternative for patients who develop an ACE inhibitor-induced cough. Similarly, angioedema is also uncommon compared to ACE inhibitors. Because of their better tolerability, ARBs are often the preferred alternative for patients who are intolerant to ACE inhibitors. Let us now discuss the major therapeutic uses of ARBs. ARBs are a first-line treatment for essential hypertension, particularly in patients who are ACE inhibitor intolerant because they rarely cause dry cough. Another important indication is diabetic nephropathy, where ARBs reduce proteinuria and slow the progression of diabetic kidney disease by lowering intraglomerular pressure. They are also widely used in chronic kidney disease, especially when proteinuria is present. By providing renal protection and reducing intraglomerular pressure, they help preserve kidney function and delay disease progression. Let's look at a few more therapeutic uses of ARBs. First is heart failure. ARBs are used as an alternative to ACE inhibitors in patients who develop troublesome adverse effects, such as a persistent dry cough or angioedema. They provide similar blockade of the renin-angiotensin-aldosterone system and improve symptoms, reduce hospitalizations, and improve long-term outcomes. Another important indication is post-myocardial infarction. After myocardial infarction, ARBs help reduce ventricular remodeling, preventing progressive dilation and weakening of the left ventricle. This ultimately lowers mortality and improves long-term cardiac function. Now let's discuss the important adverse effects of ARBs. One of the most significant is hyperkalemia, which occurs because reduced aldosterone activity decreases potassium excretion by the kidneys, leading to elevated serum potassium levels. Another common effect is hypotension and dizziness. These result from vasodilation and reduced blood volume, particularly after the first few doses or in volume depleted patients. ARBs may also cause renal impairment, especially in patients with bilateral renal artery stenosis, where kidney function can deteriorate rapidly. Finally, teratogenicity is a major concern. ARBs are contraindicated in pregnancy because they can cause serious fetal harm. Therefore, pregnancy is an absolute contraindication. ARBs versus ACE inhibitors. Key differences. ARBs are bradykinin sparing because they block the angiotensin II receptor without affecting bradykinin metabolism. Therefore, there is no bradykinin inhibition, resulting in rare dry cough and rare angioedema. This makes ARBs a safe alternative for patients who cannot tolerate ACE inhibitors. In contrast, ACE inhibitors inhibit bradykinin breakdown, causing bradykinin accumulation. As a result, common dry cough and a higher angioedema risk are seen. Despite these adverse effects, ACE inhibitors remain the first-line standard in many cardiovascular conditions. The key message is that the bradykinin sparing property is the defining advantage of ARBs and explains their better tolerability. Key takeaways. Let's summarize the key takeaways of ARBs. First, Renin-Angiotensin-Aldosterone system blockade. ARBs selectively block AT1 receptors, reducing blood pressure through vasodilation and aldosterone suppression. Second, bradykinin sparing. Unlike ACE inhibitors, ARBs do not interfere with bradykinin metabolism. Therefore, dry cough and angioedema are rare, making them the preferred choice in patients who are intolerant to ACE inhibitors. Third, ARBs have broad indications, including hypertension, diabetic nephropathy, chronic kidney disease, heart failure, and post-myocardial infarction remodeling. Finally, avoid in pregnancy. Because of their teratogenic effects, ARBs are absolutely contraindicated during pregnancy.